Good evening, everyone. Welcome to today's quarantine clinic. Today, we are discussing how to approach a case of paraparesis. In our first three clinics, we discussed the basics of neurology examination. We discussed how to approach a case of hemiparesis in stroke. And the last clinic, we discussed the differences between upper motor neuron and lower motor neuron lesion. Today, we are discussing how to take a case of paraparesis. So when I say paraparesis, I mean weakness of both the lower limbs. So in a patient who comes with only inability to move the lower limbs, that is known as paraparesis. And if this weakness of lower limb is complete, then it is known as paraplegia. And if it is partial, then it is known as paraparesis. But the difference between these two are just in the severity or the grading of the illness. The rest of the approach remains the same in both of these conditions. So in our approach to this case, we will be following the same pro forma as in any other neurological case, which is when we have a case, we want to find out everything we can about the lesion. And so we want to find out where is the lesion, what and why is the lesion. And the first step that we will look at is where is the lesion, because this is the core aspect of what we want to know. So where is the lesion in a case of paraparesis? The lesion can be anywhere in the neuroanatomy. So if we have to revise the neuroanatomy, the brain, the brainstem, and the spinal cord is the upper motor neuron part. And then from the spinal cord, you have your roots, you have your plexus, nerves, and muscle, and a neuromuscular junction. And a case of paraparesis, so weakness of the two lower limbs, can be because of a lesion in the muscle, in the nerve, in the plexus, in the roots, in the spinal cord, and within the spinal cord, it can be in the lower spinal cord or the upper spinal cord, or it could be a lesion in the brain. So as you can see, approach to a case of paraparesis, if you understand this topic completely, you have actually understood all of neurology, because a lesion in any one of these places can result in a case of paraparesis. So the way to approach it is systematically. You go from either below upwards or top downwards. So for the sake of this discussion, let's go top downwards and let us take a case of paraparesis secondary to a lesion in all of these places. One by one, I'll be giving you one or two lines in each of these areas that you can look for. So what is important in these areas? And that is how you can move ahead. So can a lesion in the cortex cause paraparesis? So the answer is yes. If there is a, now for this you have to know the anatomy of the cortex a little bit. So this is the brain, and this is the left side and the right side. You have your motor cortex somewhere like this. Okay. And some of you may remember that we had discussed the homunculus. So when what we mean by the homunculus is the distribution of the body in the brain in the motor cortex. So both the motor and the sensory cortex has the distribution of the body. So what does this mean? So if this is the motor cortex, different areas of the motor cortex supplies different parts of the body. And so the outside lateral part of the motor cortex supplies the mouth, the hands, the face, then the arms, then the trunk, and then the medial part will supply the legs. And this is true for both sides. and this is the opposite side of the mouth and the face. Now, you can imagine that if there is a lesion in the central portion, what that would do is it would involve both the legs and it would spare the hands and the mouth and the face. So this is called as parasagittal lesions. So just next to the midline on either side, if there is a lesion, then that can involve the leg area of the motor cortex, and that can result in paraparesis. So your legs, your hands and your face will be spared and only your legs will be involved. So what would you look for in a case like this? You will have all your other cortical findings. So for example, you may have headache, you may have vomiting, because this is a lesion inside the brain. You can also have bladder complaints because the bladder is also supplied by centers that are near the parasagittal regions. And you could have other, if that lesion in the brain is also involving other cortical areas, then you may have additional findings of those other areas involvement. But the main things to remember is that if it is a cortical involvement, you may have headache and vomiting. Now coming down, you reach your brain stem or upper spinal cord, that is your cervical spine. Now in both of these, so we are talking about this area, the brainstem and the upper cervical cord. In both of these, you can have a lesion that starts off as paraparesis, but eventually as the lesion progresses, there will be involvement of your upper limbs as well. So initially there may be involvement of only one leg or both the legs, but any lesion in the brainstem or the upper cervical cord, if the lesion progresses, eventually will also involve the upper limbs. So that is something to remember, that if there is a progressive lesion and gradually from the legs you also have involvement of the hands, then the where is the lesion immediately shifts to the upper cervical cord or the brainstem. Now coming to cases where you have only involvement of the legs. So there is no involvement of the head and no involvement of the hands. And this would mean that the lesion is somewhere below the thoracic cord lesion. Because as I said, if there's a cervical cord lesion, eventually there will be upper limb involvement. So if there is a lesion in the thoracic spinal cord or below, then you will have only involvement of the legs and bottom half of the trunk, but mainly the legs. So this is where our core discussion of paraparesis starts. This is purely lower leg involvement. Now, what can be the different kinds of presentation if there is a spinal lesion? Now, for this, you need to know the anatomy of the spinal cord. So this is the spinal cord, and inside the spinal cord, you have your white matter and you have your gray matter. And the white matter is on the outside and your gray matter is on the inside of the spinal cord, which is opposite to how it is in the brain. Now, within the spinal cord, in the white matter, there are these things known as tracts. And tracts are basically axons. So these are axons carrying information from one neuron to the other. And within the gray matter, you have the cell bodies of the neurons. Okay. Now, for now, we want to discuss not the cell bodies, but we want to discuss only the tracts, the axons. So what are the main tracts in the spinal cord? Now, tracts are divided into two kinds. One is ascending and one is descending. And what does this mean? When we say a descending tract, we mean that the axon is carrying information from the brain downwards, and an ascending tract is carrying information from the body up to the brain. Okay, so a motor tract will be a descending tract, because when we want to move something, that impulse comes from the brain down to the limb. So the motor tract is a descending tract, and the main motor tract is your corticospinal tract. Corticospinal tract. And there are two main ascending tracts which carry sensations. And those are the tract that carries sensation of pain and temperature, which is the lateral spinothalamic tract, and the tract that carries information about pressure and joint position. And this is known as dorsal column. Okay, so you have three main tracts. One is a descending one, which carries information about our motor movements. One is an ascending one for your posterior column sensations, which is pressure and joint position. And one is your pain and temperature sensation, which is called as lateral spinothalamic. Okay. Now, depending on the site of these tracts, the lateral spinothalamic is situated in the lateral part of the spinal cord. That is why it is called lateral. And the pressure and joint position sensation is called the posterior sensation, or the dorsal column, which is because it is in the dorsal part of the spinal cord. Okay. Now, what happens in the body because of these tracts? So let's take the corticospinal tract first. The corticospinal tract carries information from the brain downwards, and we discussed yesterday how it crosses over in the medulla and then comes down and then exits. So if you want to move your right leg, your left brain will control that. Okay. So what this means is that if there is a lesion in the right part of the spinal cord, the right leg will have a problem. Okay. Now, what about the other tracts? Let's take the pain and temperature one. So the pain and temperature sensation from your right leg will go up the leg into the spinal cord, and it will cross over at that level itself, and then it will go up. Okay. So that means that if there is a lesion in the left part of the spinal cord, you will have your pain and sensation loss in your right leg. Okay. And finally, your posterior column sensation, so your pressure and your joint position from your right leg will go up to the spinal cord. It will go up on the same side all the way, and it will cross over in the medulla and then go up. So what this means is that both your motor, that is your corticospinal tract, and your posterior column, so that is your joint position, sense, and vibration, they are both ipsilateral on the spinal level. So at the level of the spine, they don't cross over. Whereas your lateral spinothalamic tract, which is for your pain and temperature, is contralateral, which means that an opposite side lesion will cause the damage. Okay, is this clear? Or should I explain this again? So these are the three main tracts to remember. And your motor tract and your posterior column are both ascending on the same side. They will cross over in the medulla. So as far as the spinal cord lesion is concerned, they are ipsilateral, whereas your lateral spinothalamic tract, so your pain and temperature, is contralateral. Fine. So now we will take a hypothetical lesion at this level. So we will draw the spinal cord at this level and then see what happens if there are different types of lesion. Now, you have your corticospinal tract here. You have your lateral spinothalamic tract here and your posterior column here. Of course, so this is on both sides. So we have a corticospinal tract here also and lateral spinothalamic tract here. Now, there can be different types of lesions. So let us imagine a lesion that only affects one half of the spinal cord. So it only affects the left part of the spinal cord. Okay. So the left part of the spinal cord is now affected and the right part is spared. So this is the right spinal cord and this is the left spinal cord. Only the left part is affected. Now, in this case, what will happen to the clinical scenario? So there is a lesion on the left side. Okay. Now, if you remember from this diagram, if there is a lesion on the left side, what all will be the clinical symptoms? Now, you can see that the orange one, which is the pain and temperature one, will be affected on the right. So then you have your pain and temperature loss on the right side. What about your motor one? So your motor tract will not cross over. So now a motor lesion will be on the same side. So if there is a left-sided lesion, there will be a left lower limb motor problem. And your posterior column, so your joint position and vibration also will not cross over. So you have a posterior column lesion also on the same side. So if there is a left hemichord lesion, this will lead to right lower limb pain and temperature loss and left lower limb weakness and posterior column sensation loss. So in other words, contralateral pain and temperature, ipsilateral weakness and posterior column sensations. And this is known as Brown-Sequard syndrome. Okay. Now, what are the other possibilities? So what else can be the pattern of involvement? What if there is a lesion that only affects the anterior part of the cord? So it will look something like this. Only the anterior part is affected, the posterior column is spared. So in this case, the lesion is sparing the posterior column on both sides, whereas your corticospinal tract is affected on both sides and your lateral spinothalamic tracts are affected on both sides. So this is comparatively easy because that means that we don't have to think about ipsilateral and contralateral. You have your lateral spinothalamic tract involvement in both sides and your motor involvement in both sides. But the important thing to remember here is that your posterior column sensations are spared. So if you test for vibration and joint position, these will be spared. So this is called as anterior myelitis. So this is anterior myelitis. And this is seen mainly in an anterior spinal artery thrombosis. Now, let us look at the last scenario, which is involvement of only the posterior tract. So your anterior ones are spared and both your posterior tracts are involved. Again, this is simple because this would mean that your posterior column sensations are involved bilaterally and your lateral spinothalamic and corticospinal tract is spared bilaterally. Okay, so that covers your myelitis and paraparesis. Now let us get to lower motor neuron causes of paraparesis. So till now, everything that we have discussed was upper motor neuron. That is, it was above the level of the anterior horn cell of the lower limbs. And because it is upper motor neuron, all the things that we discussed in our last lecture will also apply. If it is upper motor neuron, there is increased reflexes, increased tone, there is no atrophy, there is no fasciculations. Now, everything that we will discuss is a lower motor neuron. So in a lower motor neuron, you have all the features of lower motor neuron, which is decreased tone, decreased reflexes, atrophy, you can have fasciculations. Okay? And you can have weakness, of course. So in lower motor neuron, what all are the possibilities? So let me draw this is the vertebral column, and you have L1, L2, L3, L4, L5, and then sacrum, and then coccyx. So the way the spinal cord is arranged is that the lower part of the spinal cord, your nerve roots all arise. Your spinal cord actually ends here. Okay. And from here, you have your nerve roots exiting. And they exit into the vertebral column and they leave the vertebral column at the designated areas. Okay. So right at the bottom part of the spinal cord, there is a small bulb-like structure known as conus medullaris. And from the conus medullaris comes all your sacral nerves. So S1 to S5. And from just above the conus medullaris comes all your lumbar nerves. L1 to L5. And all of these, L1 to L5 and S1 to S5, all of them will exit the cord and then travel down the vertebral column in a structure that looks like a tail of hair. And this is known as cauda equina. And at the appropriate level, the L1 root and the L2 root, they will all leave from the vertebral column. So why is this important? Because their are two patterns of involvement in this area. Supposing there is a lesion here, which is known as a conus medullaris lesion, or supposing if there is a lesion anywhere here, which is known as a cauda equina lesion. And it is important to differentiate between these two because they both involve similar structures. So what is the difference between cauda equina and conus medullaris? So the first thing is the anatomy. In the conus medullaris, the involvement is in the final bulb-like structure of the cord. And in the cauda equina, the involvement is in the nerve roots that have exited the cord. That is one. The second thing is, this is a very tight structure. So there is a small space in which there is a bulb-like protrusion. So if there is a lesion here, it is more likely to be rapidly involved. Because it is a small space, it will not take much time for it to get involved completely. If it gets involved, it will involve bilaterally because again, it is a small space. The roots that are involved is S1 to S5. So these are your sacral nerves. So all the areas that your sacral nerve fibers are responsible for, those are the sites of involvement. So your sacral nerve fibers are responsible for your perianal sensations, your bladder control, and your ankle reflex. So all these three things will be involved early. Now, in a cauda equina lesion, you have root involvement. So it is not a cord involvement, it is a root involvement. So you have radicular pain. Second, it is a diffuse area, it is a large area. So a one single lesion will take time to involve the whole thing. So it is more slowly progressive. It is more likely to start off unilaterally and then spread bilaterally. And second, the areas of involvement is your lumbar fibers and your sacral fibers. So the involvement will involve everything from your lumbar to your sacral, but depending on where the lesion is, those fibers will get involved first. So your lumbar fibers will also have your knee reflex. And your sacral will have ankle reflex. But because it is slow, your bladder involvement and perianal sensation loss will be late. Okay, so these are the main differences between your conus medullaris and cauda equina. Now, supposing the lesion has left the cord and you have now entered the roots that have come outside. Here, the lesion can be in any one of the roots, and the most common cause is a disc. So between every vertebral column, there is a disc that can come out and protrude onto the root. So that is known as radiculopathy. And the main feature of radiculopathy is that there is radicular pain and there is usually only one or two root involvement. So it is rare for a radiculopathy to cause complete paraparesis. There will only be one or two roots involvement, and gradually it may progress to involve other roots as more and more roots protrude. So there is disc protrusion. Coming to radicular pain, there are basically two types of spinal cord pains. One is funicular and one is radicular. The main difference is that radicular is because of root compression, so it is a sharp shooting pain. And funicular is because of lesions sort of inside the cord. So if there is a lesion within the cord structure, then it will lead to a funicular pain. And the characteristic is that a funicular pain is more diffuse. And you you are not able to localize it. Whereas in a radicular pain, if you have pain in a particular part of your body, it is more likely that the pain is originating from the root that supplies that particular part of the body. And that brings me to the concept of dermatomes. So I hope that you are all familiar with the concept of dermatome, because we don't have the time to go too much in depth uh, about it. But the idea is that every nerve root, will have a site of origin. So in your entire body, the sensory pattern is mapped in a particular way that each area has a particular root that is responsible for the sensations from that area. Okay, so in your hands, your the roots are C5, then C6. Now in your fingers you have C7, C6 to C7 to C8, and then your axilla is C8 and T1. The area of the nipple, that is T4. The area of the umbilicus is T10. Now in your legs, the anterior part of your legs, you have your lumbar structures L2, L3. In your foot, you have L4, L5, and then at the back of the leg, you have your S1 to S5. Now S5 is around your S2, S3, S4, S5 is around your perianal area. So this is the dermatomal distribution, and therefore, if in any one dermatome, if there is a sensory loss, then you can say that the lesion is likely to be in that root. So if there is a C5 root problem, there will be a C5 dermatomal sensation loss. Now, this is vital in this radiculopathy. So if this is a L1 root, and if there is a root compression here, then your L1 dermatome will have a sensation loss. So this is very important. So you should all know your dermatomes, and I suggest that you take out some time and revise the dermatomal distribution, because it takes a couple of revisions before you are familiar as to where one dermatome ends and where another one begins. All right, now after we have left the roots, so we have covered if there is a lesion in the spinal cord itself or in the vertebra, there is conus and cauda. We have finished the roots. Now, after the roots have left the cord, they come together as a plexus. And from the plexus, you have nerves. So the lesion can be in the plexus or the nerves, and the pattern of involvement will be that there will be motor and there will be sensory complaints. Now, the characteristic of the plexus is that usually it is unilateral. So very rarely do you get bilateral plexus involvement. Whereas if it is a nerve problem, then it is very likely to be bilateral and distal. And the reason for this we have covered in the clinic in neuropathy, that nerves usually get affected distally first and then they proceed proximal. Now this is against the next site of lesion, which is myopathy, in which the muscles are usually involved proximally first. So in a case of myopathy, the pattern of involvement will be proximal involvement. So bilateral lower limb, but proximal. Whereas if this was a neuropathy, you will have distal involvement. And they're both called paraparesis because they're both weakness of your lower legs. But in your legs, is it proximal or distal? That will decide roughly, is it a myopathy or a neuropathy? And one last point is that it could be a neuromuscular junction problem. And the characteristic feature of a neuromuscular junction problem is that it is pure motor Just like myopathy, it is pure motor and it is fatigable. So the more you exercise, the weaker you become. And when you rest, the weakness improves. So that is a characteristic of a neuromuscular junction problem. Okay. So that is the rough outline for how to approach a case of paraparesis. Once we come to where is the lesion and we are confident that we have diagnosed the site of the lesion, then you can move on to what and why is the lesion. And the way to approach this is vitamins. And this mnemonic can be applied to every level where the lesion can be. So right from your cortex all the way to spine, nerve, muscle, in each site of the lesion, under each possible etiology, there will be a list of differential diagnosis. So this is how you approach. So once you know the site of the lesion, then it is easier to go to what and why is the lesion. Otherwise, the list of differential diagnosis will be too much. Now, a couple of points on how to evaluate what and why. The main thing is history and examination. And in your history, the main thing is ODP. So what is the onset? Was it acute or chronic? That itself will give you a much better idea, because in your vitamins, your vascular causes and your inflammatory causes are more likely to be acute. So your vascular and your inflammation. So by vascular, I mean your stroke, and inflammation and infections. So even your autoimmune. So these are likely to be acute. So GBS or a myelitis, these are all autoimmune causes, and infectious myelitis. So herpes simplex, for example, these are all infectious causes and these are all acute. Whereas your traumatic lesions, so T is for trauma, so your traumatic lesions such as cervical spondylosis or even your tumors, these are more likely to be chronic. So they are more slowly progressive. And M is metabolic. So even metabolic causes are more likely to be a little more slowly progressive. Okay. And N is nutritional deficiencies are also more slowly progressive. So this is a rough outline. And depending on the cause, you will evaluate with either an MRI spine or an MRI brain, or if you're suspecting a lower motor neuron lesion, you will go for a if it's a neuropathy, you'll go for a nerve conduction study. If it's a myopathy, then you'll go for a muscle EMG, and that is how you evaluate. And the treatment depends completely on the cause. So that covers the discussion on how to approach a case of paraparesis. All right. Thank you all. I'll see you on Friday evening at 7 o'clock.